That's not bad. But could you all see my slides? Mohan. You revised the previous classes? It's just going to be 1 hour session. I will rapidly revise all the previous year question papers from INI-CET. I will not be explaining the whole of the topic. For example, if the question is about Trendelenburg, I'm not going to explain about what all the hip abductors and things like that. I'll be rather talking about the question, answer, and why rest of the things are not the answer, and probably show you some pictures. Thereby, you will have some image-based orientation to such questions. So that's the basic agenda of the class. Do you guys have any question? And as you all know, I would expect a good response from your side. The more you respond, the better will be the outcome. Okay, let's start with today's session. It is INI-CET recall questions in orthopedics, and myself, Dr. Paradiscal. So this is the first question. So the first question is about the port spine. Hope you know port spine. Yeah. So the question is about port spine, and you can see there is some disc degeneration, and it is involving 2 discs together, which means high chance it is TB, because TB involves the paradiscal area and then expands to 1 disc, 1 vertebra above and 1 vertebra below. So it is the classical picture of a TB spine and a port spine. So the question is about for which condition you will not do surgery, because they ask the word except. So you will not do the surgery. Whenever there is a doubtful diagnosis, I will do a CT gated biopsy. I was talking about that even when I was discussing discitis during the INI-CET type questions in the previous session. So you will be doing a surgery when there is a doubtful diagnosis. When the TB is not responding to the drug, then you can do surgery. And whether the person is having a TB or not, when the person is presenting to you with cauda equina syndrome, it is an emergency. It is an emergency that you have to put the patient immediately in theater to decompress the nerves there. So all these 3 are potential indication for a port spine surgery, but without a neurological complication. If you see this, the indication for operative and non-operative in TB spine. The non-operative, whenever there is no neurological deficit, you don't need to go for surgery. Okay. Whenever there is a no neurological deficit, it can be managed non-operative unless these indications are there. For example, whether there is a neurological deficit or if there is an instability which could potentially cause a neurological instability, or kyphosis, severe kyphosis or deformity, or severe infection, big abscess, very big abscess, preventing the abscess from resolve with an antibiotic, which means an antibiotic resistant TB. And whenever there is a failure of non-operative treatment for over a long time, and diagnosis uncertain, and panvertebral lesion. What is panvertebral lesion? The whole of the vertebra is involved. All these are indications for surgery, but otherwise you don't need a surgery for a TB spine. Usually it is a middle path regimen. You will put the patient on an antibiotic, wait for the patient to resolve better. If the patient is resolving from the active TB, then and still the patient is having an abscess and collection or instability, then you can think about operative, but otherwise you don't need operative. Hope you understood this topic. Guys, clear? Shall we go to the next question? See, TB spine, TB as such itself is like a favorite topic for INI-CET people, okay? TB, osteoporosis, and bone tumor, okay? So another question which was asked about port spine is where it starts. Remember, let me tell you something. So the most common type is paradiscal type, and the next common type is central anterior, and comes the posterior element. So what is paradiscal? The TB the TB usually goes through the blood vessels, right? Hematogenous route. And the blood supply for a vertebra is always like this. It goes like that and like that. So whenever a TB spreads, it is not just going to affect one vertebra. It always starts with two vertebra. Clear? Guys, are you following me? Guys, are you following me? So since the blood vessel is going like this, it always involves two vertebra. So this part is called disc. This part is disc, right? So since it is affecting just close to the vertebra, para means closer to the disc. So paradiscal means two vertebral points which are close to the disc. That is what paradiscal. That is the most common type of port spine. That is the most common type of port spine. Okay. So that is the answer. Central. What is central? Central is this. Central is this. What is anterior? This is anterior longitudinal ligament and involvement of anterior longitudinal ligament. And what is posterior? This stuff is posterior. And your spine anatomy has to be clear, okay? Because there are several times they ask questions related to what is lamina, what is pedicle, where will you put a screw, and things like that. So this is a posterior structure, and that's the spinous process. And that's the spinous process, okay? I'll show you what is pedicle, where is spinous process, where is lamina in yet another picture as well. Okay, so that's the second question. And third question, this is something related to meniscus. Come on, guys. When you see a meniscus like this, and when you take a cut section in the meniscus and look from the cut section, you will see some area which is called as a red area. And there is a next area which is called as a red-white area. And a third area which is called as a white area. So just think which area will heal better. Like simple, red area, I mean red area, red-white area, white area. Which area do you think would heal better? Obviously red area. Why? Because of the blood flow. If you see in this picture, you can see the blood flow is hitting only the periphery. So if the question is asking which zone heals with the meniscus with the injury, red zone heals better. Red zone is nothing but a peripheral zone. So whenever there is a peripheral injury, you repair, because there is a high chance for the tear to heal. But whenever there is a central injury, for example, white area damage, then you better debride. So white zone, debride. Central injury. So central injury, debride, peripheral injury, suture. Okay. Why? Because peripheral is in the red zone, which means the blood flow is better. So it will heal, high chance for healing. Okay. So this is the right answer. So that heals faster because of the blood flow. And next comes this question. Can someone try to answer this question? What do you think? Okay. So I can see some changes there with sclerotic changes. Actually, this is not a better picture. There will be much better pictures. Sclerosis is there, and also the bone is going for flattening. Okay, so this is avascular necrosis. A 60-year-old patient present with a limping gait and left hip pain. Usually tuberculosis of the hip is not painful at the beginning, okay? So 60-year-old limping and painful hip, high chance it is arthritic changes because of an avascular necrosis. Rheumatoid arthritis is usually a female disease, and it is a middle-aged disease. So it cannot be a female. And also ankylosing spondylitis, although it is a male disease, it is again a middle-aged disease. Usually patient will be in his 30s to 40 or 50, okay, and not more than that. Usually ankylosing spondylitis is a middle-aged disease, and it is not starting with the hip. It usually starts with the sacroiliitis, lumbar spine, and then it can affect the hip or whatever it is. Okay, so when the questions, so if they are expecting infectious answer, they would tell something about tuberculosis or something like that. So tuberculosis possibility is less in this question. And rheumatoid arthritis, usually a middle-aged disease. This is a 60-year-old patient. So think slightly away from rheumatoid because this is the first time he's presenting to you. And ankylosing spondylitis, more of a sacroiliac picture. Of course, hip can be involved in ankylosing spondylitis, but the age group to start with, I don't think 60 is the age group for ankylosing spondylitis. All these topics are discussed in our class during the session. And avascular necrosis, just by the excluding ABC, I'm ending up with avascular necrosis for this question. But you need to read about TB hip. Although I'm not going to take you through the entire TB hip now, you should know TB hip can start from synovitis and it can progress to arthritis as well. Okay. And TB hip can be of any of this picture. The TB hip can be normal. The TB hip can be atrophic. The TB hip can be like a Perthes. The TB hip is, in case of advanced, the acetabulum can be a traveling acetabulum. It could be a dislocating femur. It could be a protrusio acetabulum. It could be a mortar and pestle appearance. A TB hip can have all these forms. So which are stable, which are unstable, I'll leave it for you. Anyway, you must be having a screenshot of this or the video recorded. So it will be easy for you to go through later as well. So there is something called stable TB hip and unstable TB hip. And these could be the potential X-ray finding. So none of this I could see in the previous slide. So I'm thinking more of an avascular necrosis. Look into rheumatoid hip. So rheumatoid hip, you will see a joint space narrowing, and I can see a severe bone erosions. Why? Because of a severe synovitis, there is an increased blood flow, and increased blood flow resorbs more bone, and there is high bone erosion. And can you see this femur head is protruding into the acetabulum, so we call that as protrusio acetabuli. So protrusio acetabulum, or also called as autopelvis, is a feature of rheumatoid arthritis. There are heaps of causes. Okay, protrusio acetabuli can be caused by several causes, and one important cause is rheumatoid arthritis. So if there is a bony erosion like this, then you can, and the patient age, sex, everything matches, then you can think of rheumatoid. But otherwise, I wouldn't be thinking rheumatoid for the first X-ray what I was showing you. Ankylosing. The word ankylosis means pathological fusion. Right? So you will be seeing some sacroiliitis because that is a feature of an ankylosing spondylitis. And then you can also see the hip joint is trying to fuse with bony erosion and joint space narrowing, everything, all feature of rheumatoid, but added with some amount of fusion and added with a sacroiliac joint inflammation. Remember, if there is no sacroiliac joint involvement, then it is not ankylosing spondylitis. The first joint or the earliest joint to be damaged in an ankylosing spondylitis is sacroiliac joint. And then it goes to lumbar. It can come back to hip, but remember, this is the first joint. Okay, so look for when a pelvis X-ray is given, look for the sacroiliac joint, which is here. Okay, whitening, white inflammation. There is I made a YouTube video. If you can just go radiological finding in ankylosing spondylitis, Dr. Kathir, and then you will be taken to a channel called Orthomechanic, in which I would have explained what are all the possible changes which can happen in ankylosing spondylitis, be it in the pelvis or in spine, and why it is happening. What is enthesitis? What is every single sign in ankylosing spondylitis was explained in that video. If you are interested, you can go and watch. But the most important sign that you have to see in an ankylosing spondylitis is the sacroiliac joint inflammation. Any doubts, guys? And guys, are you following me? Yeah. So see, that is 50 questions and I got to finish in like 1 hour to 1.5 hours. So I'm just going to be a bit rush, okay? So I'm not going to explain every single point from every single topic. Last class, I was a bit slow because it was to introduce you to a different difficult kind of questions. But this is like more of a revision, just a repetition of what was the previous recall from INI-CET. So I'm going to be a bit fast. So this question is about deformity, and they're asking you to find out the cause. Look, this patient is having an extended hip with an abduction and an external rotation. Abduction, external rotation. So what could be the cause? Abduction and external rotation, a 22-year-old female. So what could be the cause? Remember, anterior dislocation of hip, it is very rare. It is very rare. But when it happens with an extension. It happens with abduction plus external rotation. External rotation. Sometimes in this patient is presenting with flexion, but sometimes it can be with extension as well. It looks as though it is flexed in your hip. Actually, it is maintaining neutral because the hip is dislocated and placed like that. So it looks as though it is flexed, it is not flexed, okay? But abduction and external rotation is a classical feature of an anterior dislocation. Then you can ask, of course, external rotation is a feature of both intertrochanteric fracture and fracture neck of femur. Remember, intertrochanteric fracture and fracture neck of femur may not be associated with abduction. I won't say it is not. I would say it may not be associated with abduction deformity, but the classical feature of intertrochanteric fracture and external fracture neck of femur is external rotation plus shortening. And both of these findings, external rotation and shortening, is more with intertrochanteric fracture and less with fracture neck of femur. Is more with intertrochanteric fracture and less with fracture neck of femur. Posterior dislocation of hip, which is very common. In that case, the patient will present with adduction plus internal rotation. So please remember the screenshot of this picture. See, if the patient, this is normal. If the patient is abducted and externally rotated, it is anterior dislocation. Adducted and internally rotated, then it is a posterior dislocation. Clear? Clear? And whenever there is a rotational problem along with a deformity, which is a shortening as well, then it is a fracture intertrochanteric or neck of femur. In this case, it is fracture intertrochanteric. Why? Because more shortening and more external rotation. Clear, guys? Shall we go to the next question? Yes. Which of the following is false regarding hip dislocation? See, again, it is again hip dislocation. So these guys, the important thing about INI-CET is they are not asking uncommon topics. They take a commonly tested topic and then they will go maybe a bit deeper and things like that. Okay. So just read common questions. Just read common question, guys. False regarding hip dislocation. Just a second. I'm receiving some messages from. Yeah. So which of the following is false regarding hip dislocation? Posterior dislocation of hip has flexion and adduction. True. Vessel injury. Vessel injury is more common in anterior. Remember, anterior to the hip joint, femoral triangle, right? Femoral triangle. And femoral triangle has vessels and nerves. And which vessel is there? Femoral artery is there, femoral vein is there. So vessel injury is more common in anterior. Could be true. Nerve injury is more common in anterior. Remember, the most common nerve to be affected in hip dislocation is sciatic nerve. And sciatic nerve is located posteriorly. So this may not be true. Of course, even in anterior dislocation, sciatic nerve can be involved, especially the common peroneal component of the sciatic nerve, but it is rare. It is very rare. Okay. So nerve injury more common in anterior? False. Posterior dislocation is more common than anterior? True. So the answer for this question is nerve injury more common in anterior. Remember, when it comes to hip, posterior dislocation is more common than anterior dislocation. When it comes to shoulder, anterior dislocation is more common than posterior. I think someone has... Guys, I'm hearing some mic.
திடீர்னு பயமுறுத்த போறாரோன்னு வேற எனக்கு பயம். தள்ளி நின்னுட்ட ஜன்னல் இருந்து. அப்புறம் பார்த்தா குளிச்சிட்டு இருப்பாரு.
Guys, could you hear me? Could you hear me now? Perfect. Yes. The next question. A 50-year-old boy was brought to the ER following a motor vehicle collision, complaining of pain over the hip. X-ray is given below. Again, a hip dislocation. See, all these questions are from last 3 years INI-CET. Okay, just last 3 years INI-CET 3. Okay, so in 3 years, at least 3 times the question has been asked, which means, you see, they are not asking uncommon topics at all. They are just taking the same topics and then going just deeper. So without learning the last 3 years INI-CET or the last 5 years central board examinations, don't get into the exam hall. Okay, all the topics which was previously asked will definitely be tested again. Okay, but don't expect the same questions. No way they are going to give that. Okay, now a 15-year-old boy was brought to ER following a motor vehicle collision, complaining of pain over the hip. Okay, and if they are giving an X-ray, okay, of course it is adducted. Whenever there is an adduction and hip dislocation, now I can be very sure hip dislocation and adduction is posterior dislocation. So is posterior dislocation. When I see posterior dislocation, so what am I going to do? Any dislocation is an emergency. Any dislocation is an emergency. It's an emergency. So what emergency? Why it is emergency? Because the later you reduce, higher is the joint damage that you're going to suffer. Okay, the later you reduce, higher is the joint damage and the soft tissue damage. So close reduction is the most important thing. So first thing to do is close reduction, and then in order to assess whether the head is fractured or the acetabulum is fractured, in order to assess that, then you can take a CT pelvis. Then you can take a CT pelvis. Okay, and you can do a skeletal traction. Everything, all you can do. Okay, like if it is a complicated and if it is not reducing, then you may need an open reduction. But which is most important? A is most important. Close reduction. Try to attempt a close reduction and assessment of hip stability. Okay, so that is the first thing to do. So with hip dislocation, which hip dislocation is more common? What is the deformity of hip dislocation, and what investigations will you take, and what is the first step of management of a hip dislocation, and what are all the potential complications? Where is the vessel injury, in which condition, nerve injury, and things like that. Clear? So hip dislocation is tested 3 times. And now coming on to carpal tunnel syndrome. See, I would say I'm the only faculty in the whole of the country who was talking about the contest for the past 3 or 4 years. Ever since 2019 or 2018, I was talking about DAR contest, but no time they was testing it. But the last year, or last but 1 year in INI-CET, they asked this question, which is a more specific test for carpal tunnel. Many of my fellows or my students have answered Phelan's test. Remember, this is Phelan's test. and tapping and looking for the tingling sensation in the carpal, in the median nerve distribution, is called as Tinel sign. And 2-point discrimination, this is the discrimination thing, the 2-point discrimination, the apparatus we use. Just, you see here, the 2-point is so close and it is just 1 point. The 2-point is so wide. So based on this, how much distance the patient, I mean, you know what is 2-point discrimination, right? So this is the apparatus to check that, okay? So all these can be done, but which is most common and most specific test for carpal tunnel is just pressure on the carpal tunnel, and then patient will have tingling sensation, just pressure, okay? With 2 of your thumb on the carpal tunnel, the patient will have a tingling sensation in the median nerve distribution. That is what called as a Durkheim test. Okay, and that is the most specific test. That is the most specific test. Okay, guys. So Phelan's Tinel, 2-point discrimination, and patient drawn diagram on loss of sensation. All these can be done, but which is the most specific? Durkheim. And coming on to the next question. So this question, common Dinner-Folk deformity, right? So this question is Dinner-Folk deformity. Good. I agree. What they are testing you. So they are telling few months back, and the patient has come to you with a deformity and native treatment. So 100% it is like a malunited distal radius fracture. But what the question checks, the question is not checking whether it is a malunited distal radius or not. The question is asking you whether it is intra-articular fracture or extra-articular fracture. So for which you should know what are all the types of distal radius fracture. Whenever there is a distal radius fracture, it can happen away from the articulate surface. This is the joint, right? That's the distal radius, and that's where the wrist joint located, right? So this is the joint. So the fracture line is away from the articulating surface. So it is an extra. Coley's fracture and Smith fracture, both are extra-articular fracture, but it is named Coley's and Smith based on the angulation of the distal fragment. If the fragment goes back, that is Coley's fracture. If the fragment goes front, that is Smith fracture. That is Coley's and that is Smith, okay? And then if the fracture line goes into the joint, that is intra-articular fracture, and intra-articular fractures are called Barton fracture, right? And that Barton fracture can happen at the back, that is called as a dorsal Barton. And it can happen in the front, that is called as an olar Barton. Okay, so Coley's fracture as such is an extra-articular fracture. So now, Coley's fracture is an extra-articular fracture of the wrist. Perfect. Yeah. What is Barton fracture? What is Barton fracture? Intra-articular. What is Boxer fracture? 5th metacarpal neck fracture. 5th metacarpal neck fracture. Boxing, we think it is hitting the third. No, it is actually in boxing, they do like that. So the 5th metacarpal neck fracture. Okay, intra-articular fracture of distal radius. Guys, am I too fast? Guys, am I too fast? Please respond. Yes or no? Perfect. An old lady slipped, fell. See, again, distal radius, right? An old lady fell at home and then diagnosed to have a distal radius fracture, and how you are going to manage. So, you know, AIMS, like since 2015, multiple times tested distal radius. You know, the mnemonic for the distal radius deformity is lids, right? So it is supination, impaction, dorsal tilt or displacement, lateral tilt or displacement. So whatever the movement that you are going to do, that should correct the impaction, that should correct the lateral tilt, that should correct the dorsal tilt, that should correct the supination. So you will receive the arm itself in pronation, right? The deformity is lids, so you will receive the arm in pronation, right? And then what's the first thing you have to do? In order to move the fragment, you have to disimpact the fragment. How will you do that? By giving traction. So the first thing is traction. Okay. And once that is done, you are correcting the dorsal tilt and the dorsal displacement by palmar flexion, right? So palmar flexion, and then ulnar deviation, and then put the POP. Okay. So you have to correct the deformity. So in order to correct the deformity, you have to release the impaction. So this is definitely not the answer, right? And once you disimpacted, the first thing you should do is palmar flexion and then ulnar deviation. Okay, just before putting a POP, you can do an ulnar deviation. Okay, so that's how we pretty much reduce the distal radius fracture. So distal radius fracture 2 times in the last 3 years. And the next question is, a 60-year-old woman with history of Colles fracture 8 months ago comes to orthopedic outpatient department. T-score is again Colles fracture, but this time it is not about distal radius fracture. Rather, they are telling a person, see, distal radius, distal radius, distal radius, why it is happening more common in elderly because of the osteoporosis. And this person, they have told you what is the definition of osteoporosis. T-score minus 2.5 is the definition. Anything less than minus 2.5, minus 3.5, minus 2.9, everything is osteoporosis. So they have given you the definition that this patient is having an osteoporosis and what you are going to do. See, although this patient is postmenopausal, see, attained menopause at the age of 52 years, and now the patient is 60 years, which means like postmenopausal 80 years. What you are going to do? What you're going to do, I will give alendronate. I will give alendronate. Okay. Bisphosphonates are the first line treatment. Some people once were thinking about hormone replacement therapy. Maybe like even 4 or 5 years back, people in a postmenopausal, it is hormone replacement. If it is a case of a senile osteoporosis, they will just go for bisphosphonates. But nowadays, the first line of treatment, whether it is a women or postmenopausal or premenopausal, if you are diagnosing an osteoporosis, the first thing you should be giving would be a bisphosphonate unless it is contraindicated. Unless it is contraindicated. Okay, clear, guys? Clear. And when you are giving bisphosphonates, you should always supplement it with calcium and vitamin D. Why this concept is important, I will explain you in the next slide. In the next osteoporosis question. But before that, try to answer this question. Scoliosis screening in school children is done by actually, in countries like Australia, it is like a screening program. Like grade 5 to grade 8, all girls would be asked to bend, and the school PT teacher would assess the curvature. If this is normal, but that is abnormal. Okay, this test is called as ADAM test. ADAM test. So this is done by asking the patient to bend forward, and even my workbook which was supplied by ADR, we are having that. Okay, so forward bending test, which is called as an ADAM test, Okay, to assess scoliosis. If you carefully see into this picture, it is a female. And also this girl, I told it is 5th standard to 8th standard, which means like 10 years to 13 or 14. So adolescent. So if you see this picture, what are all the points you should recollect from scoliosis? It's a female predominant disease. It is an adolescent disease, and the ADAM test is done. There are certain types of scoliosis which is male predominant. If you go read the scoliosis topic again, you will understand which, but that is uncommon. That is uncommon. Okay. The predominant type of scoliosis is female adolescent type scoliosis. Okay. Coming on to fishtail deformity. Fishtail deformity is a supracondylar, same like shoulder dislocations. Another important topic. Same like distal radius fracture. Another important topic is supracondylar fracture. Okay, multiple times they ask questions. So the last time what they have asked is fishtail deformity. What is fishtail deformity? Basically, this is what fishtail. If you see, like a fish. So this part in the trochlea, now you see. So whenever there is whenever there is a distal humerus fracture happening, what happens is the trochlear ossification at this part is damaged. So once the trochlear ossification is damaged, rest of the bone grow normally, but that ossifying trochlea may not ossify well enough to show in an X-ray. So it shows like an osteolysis, and that leaves a dent in the distal humerus. So that is what called as a fishtail sign. So they may not give you this X-ray, or they may give you the X-ray. Okay, so in which type of fracture? Usually any distal humerus fracture, especially when it involves the medial side, because that's where the trochlea is. So usually medial, excuse me guys, it's close to 2 a.m. in Sydney, so I'm just finding a bit sleepy. But if you are finding the class boring, please let me know. Okay, yeah. So coming into the distal humerus fracture, when the trochlea is involved, the trochlea can go for a poor ossification or osteolysis and leave this sign called as a fishtail sign. Supracondylar fracture, medial condylar fracture can have these kind of impact. Okay, but so the answer for this question is the distal end of humerus. But what other question, potential question which can be asked? The potential questions can be crescent sign. What is crescent sign? Crescent sign is again a sign in a supracondylar fracture, in which if you see the capitulum of the distal humerus just merges with the olecranon and form a crescent. Can you see a crescent there? Can you all see a crescent there? Okay, that is what called as a crescent sign. Again, that indicates a varus or valgus tilt in supracondylar fracture. Coming on to what is this sign? This sign is the fat pad sign. Can you see the bone and some radiolucency there? That is called as a fat pad sign, another sign of supracondylar fracture type 1. Hope you know what is type 1, type 2, and type 3 Gartland classification of supracondylar fracture. So type 1 is an undisplaced type. Coming on to next question. Ring sequestrum is seen in which condition? Ring sequestrum is seen in pin tract infection. What is pin tract infection? By the word pin tract infection, which means I have, during the last class as well, I was explaining you there is something called as an external fixator. We will put a pin in the bone and then fix it with an external rod. So that is what called as an external fixator. But sometime when the infection travels from the skin through this to the bone and then cause a sequential dilating osteomyelitis, which produces like a ring-like sequestrum, and that is what called as a ring sequestrum seen in external fixator. Other type of sequestrum based on the shapes can be a tubular, black, coralliform, coke, sandy, feathery. Every different type of sequestrum is having its own potential causes. So feathery is seen in syphilis, sandy is seen in tuberculosis, coke or rice grain, again tuberculosis. Coralliform is Perthes, black actinomycosis or fungi, tubular pyogenic. So these are again a sequestrum based on the shapes. These can be a potential question as well. Now, coming into tennis elbow, even during the last class regarding a potential NEET topic, I was asking about tennis elbow, and they did test your knowledge on tennis elbow, right? So what is a counter brace used in? Counter brace is used in tennis elbow. What is counter brace? You know, tennis elbow is because of an extensor or lateral epicondylitis, which is here. And the most common tendon to be involved is extensor carpi radialis brevis, and then extensor digitorum communis. These two are the tendons. So if this is happening because of an extension, then some people think if you by any way prevent the movement of this tendon at its proximal insertion, then you may prevent the pain, right? So that mechanism is called as counter brace. Putting a brace there, tightening it and taping it, thereby the muscle won't be moving when you are actually trying to extend your wrist joint or flexing the wrist joint and stretching the tendon. This is what called as a counter force brace, just to keep the proximal muscle stable when there is a movement happening at wrist. This is called counter force brace. since it works against the force of your muscle when it is getting stretched. It is called counter force brace, used in tennis elbow. Not very successful, not very successful in my practice. I mean, I've been doing orthopedics since 2015, right? As a PG, now till a fellow in Sydney. I would say hardly to 2 or 3 patients I would have written this. Okay, and I don't feel it is greatly useful, but still it was tested, right? And you know this test. This test is Cousin's test, and that test is Mills test and Maudslay's test. Maudslay's test. Hope you know what is Cousin, what is Mills, and Maudslay's test. I have explained it during the previous session as well. And coming into this question again, tumor. When you go through this PowerPoint presentation at the end of this session, again, you will come to realize they are asking questions from the same topic again and again and again, right? Tumors. They'll ask at least 2 or 3 questions. Every year you will find at least 1 question from tumor, 1 question from tumor. So 1 year they had tested osteosarcoma. The question was just displaying this picture, okay, and asking what it is. Distal femur metaphysis, 10-year-old kid. Come on. If it is a diaphysis, you can think of Ewing sarcoma at least, but it is a metaphysis, distal femur, 10-year-old boy. No other option other than osteosarcoma. Osteoid osteoma can happen in 2nd decade or 3rd decade, or sometime 4th decade, but it is a diaphyseal lesion, right? And giant cell tumor is epiphyseal lesion, right? And chondroblastoma again can be a metaphyseal and diaphyseal, but this is more of a bony tumor, right? So I feel osteosarcoma, easy question. Hope you know pain is the first finding and then swelling is the next finding. Pain is the earliest. And you know sunburst appearance and periosteal elevation or Codman triangle. Right? All these are must-know topic or words before you entering the exam hall. Coming on to this question. Come on, guys. This is, I've been explaining what is osteoconduction, induction, and osteogenesis since 2018, but very rarely they are tested. And 1 time in INI-CET it was tested. So the question asked was, which of the following substances used for bone formation in a patient with non-union, which means which of the following is an osteoinductive material? These 2 are just calcium salts. They can never be an inductive material. In order to call something an inductive material, it should go and stimulate an osteoclast or an osteoblast to say, go and unite this bone, right? So they have to be a chemical factor, which are not just giving physical property, which are not having physical property, but chemically go or genetically or like a growth factor. It should go and stimulate an osteogenic cell, right? So then it is called as an osteoinductive. Osteoconduction is physics, osteoinduction is chemistry, and osteogenesis is biology. So if you're keeping an autograft, that autograft has an osteoclast, an osteoblast, everything in it, and it is not killed by your immune system because it is an autograft. That is an osteogenic. But the question is asked is not osteogenic. They asked which of the following, when it is given, it will go and promote the bone formation, not, which means osteoinduction, which means we are looking for the chemical substance. PMMA is a bone cement. It just provides structural integrity. Whereas these are salts, they are purely physical, which means osteoconduction. What is bone morphogenic protein? They are a transformation growth factor, TGF kind of things. And it is a chemical substance which goes and stimulates an osteoblast and clast to come into the picture and start the bone formation. Clear? So that's the answer. B is the correct answer. So the question asks, what is the brace shown? This is the brace they have asked. So that brace is Milwaukee brace. So how will a Boston, all these are braces usually, you see, Milwaukee and Boston is usually done for scoliosis, and Ash brace is usually done for kyphosis and postural correction, and a Taylor brace is usually done for osteoporotic fractures of the vertebra, right? So for elderly fracture, spine, if it is stable. If it is unstable, you go and put an operating, right? So all these braces. So the first brace is Milwaukee, and the second brace, what I have shown is Boston, and the third is a Taylor brace, and the fourth is the Ash brace. Usually we don't pronounce with E, ASH brace, okay? But in exam, they have asked ASHE brace, okay? So the tested one was Milwaukee, but you should know Milwaukee has just rods above, but without rods, if it is all plates, then it is Boston brace. And with just 2 rods, rest of the thing is mere cloth, then it is Taylor's brace. And a hyperextended rods just at the front, something like a crucifixion plus in the front, then it is Ash brace. Clear, guys? Clear? Guys, yes, no, I'm not seeing anyone. I would really love to see some response. Perfect. So, next. A 40-year-old man is suffering from increasing difficulty in bending forward. That's a good question. 40-year-old man, middle age, and a man. They said it's man, which means a male, bending forward with increasing stiffness of spine and reduced chest movements. I told you, lower spine involvement and a middle-aged man, high chance it is ankylosing spondylitis. But still, the question hasn't mentioned anything about sacroiliitis. So I could also think it could also be dish. But dish is slightly an older disease, older people disease, while excuse me, while ankylosing spondylitis is a middleman disease. It is a middle-aged disease, okay? So despite sacroiliitis is not shown in the given X-ray, the classical movement restriction of the lumbar spine and the chest, because both dish and ankylosing spondylitis, both are ascending arthritis, which means it starts from below and goes up, sacroiliac joint, lumbar joint, and then, right? Why this is not rheumatoid arthritis? Because remember, rheumatoid arthritis, the most common cervical segment to be involved is cervical. It is not lumbar. It is not going to affect your chest movement. Of course, it can cause some restrictive lung diseases. I agree. Felty syndromes and Kaplan syndromes and things like that. I agree. But a chest movement, nah, I don't believe in it. Okay. And if at all there is if they have given a spine X-ray, as in this case, can you see that? As in this case, that is a rheumatoid arthritis. That is rheumatoid arthritis. Okay, that is rheumatoid arthritis. Can you see this? Can you see a candle wax dripping appearance? That is dish. Linear marginal osteophytes is ankylosing spondylitis. Linear marginal osteophytes is ankylosing spondylitis. So, guys, I'm not just explaining one option, why it is right. I'm also putting 3 different pictures to make sure that you understand like how a rheumatoid arthritis would look, how a dish would look, how a ankylosing spondylitis. If you had attended my ADR class online, then you would have seen me describing the difference between osteoporosis, ankylosing spondylitis and dish. The next question, in spine fusion surgery, the screws are fixed to which part of the vertebra? Remember, we They were asking about port spine and then again spine related questions. See, they are fascinated about spine. So you should know about at least the anatomy of the spine, right? So the answer is pedicle, but the question also says something called lamina. We all know spinous process. That is the spinous process, right? But most of the time people get confused. What is lamina and what is pedicle? Remember, pedicle is this. That is pedicle. Do you remember during my class in ADR online session, I would have explained a vertebral column. In a vertebral column, when you are taking an X-ray, you will see two eye. And in a metastasis, that eye would be missing, winking owl eye appearance. That is a feature of metastasis. And what basically the two eyes are nothing but the pedicle. So where you put the screw, I'll put the screw in the pedicle, right in the pedicle. So that is, so where I put the screw, that is in the pedicle. So where is lamina? Where is lamina? This is lamina. Do you think this part, flimsy part, do you think it can hold any screw? No way. No way. The most robust part there in the spine is the pedicle. So in order to stabilize the spine, you should choose a pedicle screw. Facet joint cannot withstand a screw. Spinous process cannot withstand a screw. So no way these two are answers. And lamina, it is very close to the nerve. No way I'm putting any screws in the lamina. So the answer is pedicle. Clear, guys? So this is how it goes. In all angle I have shown you. This is how it goes. And this is how it goes. And this is how it goes. And that is lamina. That is lamina. Clear? So please remember the anatomy of spine that can be tested again and again. So the next question, I was telling you, right? Dislocation. There's something fascinating about dislocation. Another question. In last 3 years, come on, this is like the fourth or fifth dislocation questions we are seeing, right? 3 or 4 from hip dislocation, and now again a shoulder dislocation. Come on. So shoulder dislocation, which nerve is affected? So whenever there is a shoulder dislocating, it is ripping the capsule and the nerve coming like that and then going and just encircling the surgical neck of the humerus. That is called as an axillary nerve. So axillary nerve is stretched and usually neuropraxia. And which two muscles that axillary nerve supplies? Deltoid and teres minor. So what is the action of deltoid? Abduction is affected. But remember, teres minor is supplied much early than the nerve coming and encircling, much ahead of the nerve coming and starting to encircle the humerus. So usually teres minor escapes, but deltoid is affected, and thus abduction of the shoulder is affected. Right? Easy question. Rest of the nerves, it's totally very much away from the shoulder joint. Median nerve, radial nerve, and suprascapular nerve, very much away from shoulder joint. Suprascapular nerve just goes there. It is not even crossing here. It just goes there, supplies the supraspinatus, and then goes down and supplies the infraspinatus. That's it. It has no role to come closer to the humerus at all. So suprascapular nerve is of no use to be thought as a potential answer. Coming into this question, this X-ray was not given in the exam. X-ray was not, just for the sake of explanation I have given. So the question was about the unilateral knee pain in a 72-year-old, unilateral potential cause. Could this be tuberculosis? Could be. Rheumatoid, less chance because it's a middle-aged disease. Lyme's disease, infection, okay, let me think about fever and things like that. Let's look for that. So they said just a 72-year man complains of unilateral knee pain. Now the complaint. And X-ray shows a reduced joint space. So that question literally begging you to diagnose osteoarthritis. So pathological finding. So this is a rheumatoid nodule and there is a caseating necrosis. So that is TB. That is a rheumatoid nodule. So this must be OA. So what I have shown you is an OA of the grade. So basically, just to show you that the joint has gone for degeneration and multiple osteophytes coming out, right? But something similar to that, you will see a hyaline cartilage. The hyaline cartilage is being broken, and then you will see some osteophytes and things like that. So those are all the histological changes that you will be seeing in osteoarthritis. Another question from tumor. I was telling you, right? Tumor is very, very common. Another question from tumor. So this question, a 35-year-old man present with a knee pain, the X-ray of the knee joint is given below. What is the probable diagnosis? See, is this metaphyseal or epiphyseal? Definitely it is epiphyseal and extending to metaphysis. So epiphyseal plus metaphysis in a third decade person, 30 to 40, third decade person, third or fourth decade person is the diagnosis epiphyseal. This age, there is only one diagnosis I would say. It is osteoclastum. Okay. And proximal tibia. Remember, don't diagnose this based on sobubble appearance. Of course, sobubble appearance can be there, but even in aneurysmal bone cyst, you can have a sobubble appearance. Okay, so don't diagnose giant cell tumor just because of the sobubble appearance. Look into epiphysis. A fused epiphysis with an epiphyseal-metaphyseal involvement of a bone tumor, an osteolytic lesion, expansile, then think of osteoclastoma. Osteoclastoma is something like having an hall ticket for your exam. Okay, if you're not reading osteoclastoma, it amounts to severe mistake, like you haven't got your hall ticket for the exam. Clear? So osteoclastoma, see at least 10 or 15 osteoclastoma and aneurysmal bone cyst X-ray to understand how different it looks. When it comes to aneurysmal, the epiphysis is paired, but in osteoclastoma, the epiphysis is involved. Coming on to book test, this is a nerve test things. So what does the book test basically do? So what does it do? See, when I'm asking a person to hold like that, he should hold it by, hold it with adduction, right? So adductor is the only thenar muscle supplied by the ulnar nerve. Rest of the thenar muscles are supplied by the median nerve. Right? Rest of the thenar muscles are supplied by the median nerve. Okay. So I'm asking a person to adduct and hold a paper. But instead of adducting and holding a paper, when I'm trying to pull, since the ulnar nerve is not functioning, he will flex with the flexor pollicis longus and hold the paper. Can you see that in the picture? Instead of adducting, he is using FPL. Instead of adductor pollicis, he is using flexor pollicis longus. So his median nerve is intact, but ulnar nerve is damaged. So it is a finding to assess which nerve, ulnar nerve. It is to assess which muscle, adductor pollicis. Clear? So the next question. A 6-year-old sustained a fracture of a lateral condyle of humerus. Again a nerve-related question. Come on. Which leads to development of an elbow deformity. A lateral condyle of humerus fracture. What deformity can it cause? A cubitus valgus. A cubitus valgus in a child, when it is growing, can cause what palsy? Tardi-ulnar palsy. So whenever there is an ulnar nerve involvement, which muscle in the hand is involved? Remember, out of 20 muscles in the hand, nearly 15 muscles are supplied by ulnar nerve. That is the reason why it is called as musician nerve. And you know now, ulnar nerve is the one which is supplying 4 dorsal interosseae and 4 palmar interosseae, and palmar interosseae is responsible for the adduction of fingers. So which muscle is involved now? Palmar interosseae is being tested in this picture. And palmar interosseous is supplied by which nerve? Ulnar. Okay. Inability to adduct the fingers. Inability to adduct the fingers. Ulnar nerve. Ape thumb deformity. What is ape thumb deformity? Which is also called as a simian hand. What is simian hand? Usually, our hand is like this, right? The thumb is much away from the rest of the fingers. Guys, are you all listening? How many of you are listening? Just put your hand up. Yeah. Perfect. See, the regular normal hand is like this, right? But when the median nerve palsy, when the abductor pollicis is affected, what will happen? The intact ulnar nerve will pull the thumb more towards adduction, because ulnar nerve is the one which is supplying the adductor pollicis. Do you all agree? So this looks like a human hand. What does this look? Just an adductor is working. What does this look like? This look like a monkey hand. That is what called as ape thumb deformity. How many of you learned what is ape thumb deformity just today? Just today. Oh, sorry, I don't know what is ape thumb deformity. I know it is because of median nerve, but I don't know what is ape thumb. How many of you learned this point today, just today? Now, if you know previously, then say, I know. Something, guys. I want some response. Just today. Okay. Good. Oh, Mohan Raj. That's great, Mohan. That's great. So little points, what is a trident hand in achondroplasia? Trident hand is usually every hand has a 5 rays, but a trident hand just has 3 rays. Can you see? Only 3 rays. So that is a trident hand in achondroplasia. So little things, it is better you give little more attention to understand what it is. Okay. Point. So ape thumb deformity is a median nerve. Pointing index sign is again a median nerve, because when you are trying to flex, all finger flexes, but not the index finger, right? Because the median nerve is the one which is supplying the flexor digitorum profundus of the index finger. So it looks like a pointing finger. So that is again a problem of a median nerve. And Kilonevin sign is again anterior interosseous nerve, which is a branch of median nerve. So only this is an ulnar nerve. So that is the answer. Clear? Now, coming on to this question. A 65 postmenopausal comes with a persistent backache. Good. She has a history of lifting heavy weights 4 months. Oh, 65-year lady, heavy weight for 4 months. Obviously, something to do with her back. Progressively increasing pain that worsens on. The pain starts radiating down her leg after walking a distance of around 100 meters. However, she feels no pain on walking uphill. What is the most? No pain on walking uphill. What does it say? Which means this is not related to vascular arterial pathology. This is not vascular claudication. So not vascular claudication. Claudication, right? Walking uphill is not a problem. So no vascular claudication. So what is this? This is a neurological claudication. What is neurological claudication? Atherosclerosis is vascular. Thromboangiitis obliterans is vascular. And remember, thromboangiitis obliterans is more of a male disease. The question is female disease. Osteoporosis, compression fracture. They are talking about nerve-related findings. Yeah, they are talking about radiculopathies. So compression fracture alone cannot cause a radiculopathic symptoms. Rather, it is a focal pain, right? Unless it is a not really unstable compression fracture, jetting and cutting the nerve. Okay. So what we need to now, after ruling out this, and that, we are left with only option B. So the answer is lumbar stenosis. So the answer is lumbar stenosis. Clear, guys? Now, the next question. Following a road traffic accident, a patient belonged to type 3A compound tibial fracture. Arrange the following external fixator in decreasing order of stability. That is a very good question. Elisora fixator. Remember, Elisora fixator is a circular fixator. And at every circle, 2 wire goes into the bone. or at least one wire, and all the circle is connected with 3 or 4 rods. Among all this, which is the most stable? It is ilicerol. It is ilicerol. So the answer now is either A or C. So all you need to think is, what is the second most? So they have given either 2 or 4. Now look into 2. 2 is uniplanar with a single rod, and 4 is biplanar frame or with a cylindrical rod. Naturally, biplanar with a ring must be the more stable construct. So I should think of C. Clear, guys? Mohan, good, Mohan, you answered it well. I appreciate it. Clear, guys? Is everyone understanding it? What is uniplanar? Remember, this is the bone. Okay. What is uniplanar? If you are putting wire from pins from only one side and attaching one rod, that is uniplanar. What is biplanar? Biplanar, one goes in this axis and another rod goes in this axis, right on top of the bone, just perpendicular to the bone. Then that is biplanar. There is one in the y-axis and other in the x-axis. So 2 plane is fixed now. So that is what called as a biplanar construct. Okay. So that has to be more stable than a uniplanar construct. So the answer is C. Next question. This question is about Trendelenburg. Come on, guys. Trendelenburg, the only thing that you should know, Trendelenburg, which leg is the affected leg? When this hip is falling, when the pelvis tilts down, the opposite abductor is the problem. Abductor mechanism is the problem. Right? Right? So which limb abductor mechanism is problem? Standing limb. Standing limb abductor mechanism is problem. Which limb is drooping? The lifted limb is drooping. Is the problem lying on the lifting limb? No. The problem lying on the standing limb. On the standing limb. I carefully used the word abductor mechanism. I didn't use the word abductor muscle. What is abductor mechanism? Abductor mechanism involves abductor muscle and the nerve supply, which is superior gluteal nerve, and the muscle, and the insertion of the muscle, greater trochanter, and the lesser trochanter, and the intertrochanter, and the neck of femur, and the femoral head. So, if any of this is affected, Trendelenburg test is going to be positive. Superior gluteal nerve palsy, or a disc prolapse impinging on superior gluteal nerve root values, or an abductor palsy, which is a gluteus medius and gluteus minimus palsy, or a greater trochanter avulsion fracture, or an intertrochanter fracture, or a neck of femur fracture, or a femoral dislocation. Anything and everything in this can cause a Trendelenburg positive, or an arthritis of the hip joint. Everything can cause a Trendelenburg. So is this assessing hip adductor? No. Is it assessing flexor? No. Any lateral rotators? No. It is assessing only the hip abductors. So the answer is A. Clear? Shall we go? Next. CTEB, as early as possible, start the correction. So the question, you are watching CTEB, when will you put the patient on cast? As early as possible, which means in a few days, within days, start the baby on POP within days, CTEB within days. Okay, there is no role in correcting it late. And just look into the picture of CTEB that was tested again. So there is an equinus. So every option is having equinus. Okay, so with this, I cannot correct it, right? Planus is what we are having, a flat foot or things. This patient is not having a planus, right? No. So either A or B or C. Then I look into the forefoot. The forefoot is coming towards the midline, which means it is a forefoot adduction. So option C is ruled out. Option D is ruled out, right? So now, is it inversion or eversion? Inversion. So now A is ruled out. So the answer is B. It is equinus, varus, supination, inversion, forefoot adduction. One, two, three, four, five. Clear? Clear, guys? Next. Come on. This is a beautiful question, right? They said raised serum ALP, irrespective of type of rickets, whether it is a dominant rickets or a resistant rickets, whatever type, dependent vitamin